Uh,
Everybody see that?
yes.
Great. I want to thank Terrence for inviting us onto this webinar on rotator cuff repair. We're going to be having a great hour or so of discussion and debates on some kind of different types of cuff disease and problems, nothing really ordinary. I want to introduce my star faculty here. I'm Anand Murthi from Baltimore. I'll be moderating. Grant Garrigues from Midwest Rush Shoulder Specialist has been really one of our young and upcoming stars. Paul Sethi, my brother from another mother, is president of his group in shoulder and sports medicine in Greenwich, serving the underserved and underprivileged of Greenwich, Connecticut. And Steve Brockmeier, our sports and shoulder professor from University of Virginia. So we've all known each other for quite some time, and we're going to debate this out and have some fun. And I want to thank Terrence and his crew for the invitation. So let's get right into it. This is a 45-year-old with right shoulder pain. Has had a lot of problems for a couple years. Importantly, he had an ankle repair, one ankle 3 years ago by Dr. Sethi for a massive cuff tear at his surgery center. Smokes a little bit and is a hairdresser. Mild atrophy on exam, but still good function, good passive motion. He's got a strong deltoid, and this is what it looks like. So I'm going to start with Grant. Take me through what you see here.
Yeah, so you got the MRI cuts there showing a full thickness rotator cuff tear. I guess it'd be a re-tear technically in this case.
Correct.
It looks to be anterior superior, and there's you got some retraction, and the muscle quality looks relatively decent. That's my initial impression.
Paul, how about you?
A couple things. One, I'm glad, Anand, that your previous job as a hairdresser came out here. But Grant, when you look at the sagittal section there, I mean, I think the muscle looks a little atrophic. Like we can argue. Or how would you grade that Goutellier? That's at least a 2 or maybe even a 3 to me.
I give that a 1. I think there's some fatty shrinks in there. I think the fact that there is some, it looks like atrophy, but really it's that the tendon is a fusiform shape, and since it's retracted, you're getting a different cut than you normally would if that tendon was out under full tension. I think if you grab that tendon and pulled it out, it would fill up that space a little bit better.
So Steve, these guys are just talking a lot of gibberish. What would you do now? You see this wonderful patient who's motivated. What's your plan right now after seeing her exam and her MRI imaging?
So these are tricky. I do side with Grant a little bit. I think the muscle looks doable, looks salvageable. It's a younger patient, obviously a high demand profession. So this, I'd offer her a revision repair. This is one where actually I do think that something extra probably makes sense. Number one, it's a revision. Number two, it's probably compromised healing environment because of the smoking, and you do need to get a pretty good outcome functionally if she's a hairdresser, he or she's a hairdresser. And so this is one where I'd probably do a scope repair, multiple anchors, add a patch, maybe even consider a little bit of a biologic here, depending on kind of how much I was trying to go for it. And the only thing you didn't show on him was the subscap, but this is a pretty far anterior tear, and so I do worry that there's probably some subscap involvement, and so I'd be cautious with that too.
Okay, always good to check the subscap. Anything different, Paul or Grant, that you'd do? Short answer.
It looks like on the first surgery I left the biceps alone, so I must not have been thinking clearly. I agree with everything Steve said. This is one of those kitchen sink cases. The person's only 45. This is your last shot. And the biceps may play a role in what I do.
This is what it looks like from our posterolateral portal. I've already scoped the joint, which is normal. Posterolateral portal instrumented from anterolateral. This is what it looks like. Grant, any differences in interop? You're going to make any changes to your plan? Single row, double row?
No, it looks, I mean, we'd have to pull on it and see how it wants to lay down. There does appear to be a delamination component to this. There's not a lot of tissue left on the tuberosity, or perhaps you've debrided it away. So, again, I think you're going to want to have this person stop smoking. You're going to want to do an augment that has some structural integrity. So for me, that's some sort of dermal graft or xenograft. And then I think you're going to want something that's going to rev up the biology like a BMAC. So I'm going to throw the kitchen sink exactly as Dr. Sethi said.
Paul, what would you do here?
Look,
She came back. I sent her back to Connecticut.
That's good. That's good. Well, I'm very pleased that I didn't disrupt the tissue quality significantly. And Grant's point, I think we should just underscore it for a minute, is he says you have to pull on it. It's a lot like a fracture reduction to me, right? So you want to pull on it in a couple of different angles. You may try something like putting a suture through the tendon to see what the pullout is as you use that as your reduction tool, and trying to decide how to get a low tension repair. Whether that means it's a single row or a double row, of course we'd all prefer more points of fixation, but getting a low tension repair where you can reduce the tissue back to normal, venting the bone underneath it, and then exactly as the guys alluded to, I would consider using a dermal augment, not a bovine, but something with 3 millimeters. Adding the bone marrow aspiration. Now, look, this is an interesting one, right? Because I'm involved in a study where we're looking at this. The quality of the humeral head bone marrow aspirate does not have the same number of pluripotent cells as the hip.
Iliac crest.
Yeah, so it's a sort of real dilemma, because by the time you get the person positioned and you decide you're going to do it, and then you need to get this, you're kind of draped and stuck off here or there. But I just don't know.
So my plan was to do bone marrow, and I agree with you. So the colony forming units are different in all these bones: hip, iliac crest, humerus, whatever. But we don't know yet what that minimal threshold number is. I don't know, maybe Steve or Grant do, the biologics whizzes. But this allows, so I've done both. I've taken it when they're supine, pre-op, take the crest bone graft. This is really simple, as you guys know, to take it from the humerus while you're prepping for your cuff repair. This was a single row, a couple of anchors. The excursion wasn't great, so I didn't want to put extra tension on it. We utilized this as an absorbable graft. I think Steve has some history or knowledge of this graft. It's an absorbable type of graft that acts essentially as a washer for suture management and holding your sutures in place. So we repaired, got a single row repair, and then injected with BMAC under dry arthroscopy. What do you think, Steve? Is this going to work?
Yeah, I like that, actually.
Magic or?
Yeah, no, I think that's a really good way to approach it. I've gone towards more dermal grafts just because of their strength and integrity, but I actually think this particular graft is great here. It resorbs over time, so you're not left with anything behind, but it really wicks up the biologic really well, so it has that advantage. You can see, just how kind of red and vibrant that looks with putting the BMAC in there. I do tend to not, I haven't been all that impressed with the humeral head aspirates. I think it's actually harder than, I don't know, at least for me, it's been harder because you got to dry it out and you got to, it takes just as much time for me as it does just to prep out the crest initially, take your graft or take your cells and then go do your case. But other than that, I think this looks like a great approach.
I think, Anand, just underscoring that you did a single row repair and a revision is so important, because we all feel so compelled to run to double row on everything. But just talk me through how you made the decision on tension, because I think that's something to get out.
If I can't, after doing all my releases, capsular release, superficial release, interval, if I can't get that past half the tuberosity, then I'm going to do a bit of a medialized repair with a graft or BMAC and venting. When you medialize it a little bit, you actually can vent more too on the tuberosity footprint. So, I don't, just jump in and say I'm going to do double row on everything, because I've seen such over-tensioned repairs, and then you can get a type 2 re-tear, then you're done really, where it tears at the muscle tendon junction. So I think low tension especially on a revision is a good option.
Anand, how much do you feel comfortable medializing? Like if you're going to medialize that articular surface, is it 3 millimeters, 5 millimeters, 8? What do you feel comfortable with?
So when I reduce it, I want to have at least 5 millimeters of bone, of cancellous prepared bone. So I'll measure that and make sure I have at least 5, which is, it's about a half or a third of a regular tuberosity footprint. So this is what it looks like afterwards. I think this was about 6 to 9 months later. Did well from the bone graft. She didn't go to Sethi for the revision. Didn't like his bedside manner. So 1 year later, she's back hairdressing, COVID time, back to work and doing well. So we're going to go to our next case now. This is a really great case, very good patient, 52-year-old female, developed Parkinson's over the years that I had known her. Very active, likes to work out in the gym, lots of pain, has had bilateral cuff surgeries. So this is a revision setting. She has good elevation, good flexibility. She has a really prominent lag sign at the side. So this thing bounces back and she can't reach things, get to her hair. And she's super motivated. This is her in the gym. So you know she's in good shape. She's very muscular, likes to swim as well. So I think you have to take into consideration the host. So Brock, what do you think about these MRI photos?
Yeah, this is a tough one. The Parkinson's is something that gives me a little pause as well, but obviously she's definitely overcoming that that limitation, it would appear based on your photos. So she's got a high riding head on an MRI, which I don't know necessarily impacts my decision making too much, but something to take into consideration. I don't see much of supraspinatus tendon. That looks medialized beyond the glenoid. The muscle on that middle view looks, that to me is a Coutelier, probably a 3, as best as you can tell on that one cut. And it looks like her posterior cuff is largely torn all the way down to at least the infra, if not into the teres minor, and then the subscap. It's hard to tell, but at least there may be some involvement there. So this is a tough one, and this is where you're looking at more salvage options, I would think.
Mm-hmm. All right, so you give me one answer. What's your choice?
For surgery?
Mm-hmm.
It's a tough one. Again, she's probably one where you're looking at salvage options. She's in her early 50s, so I'm a little hesitant to jump right to reverse, but I mean that's going to be, in the end, probably the most predictable option. But somebody in their early 50s, you could consider a tendon transfer in this patient.
I mean, I think the buzzwords that you said on and that sort of draw me are lag, right? When someone has a lag, I think it really changes how you have to think about ththings. And then she's got no reparable cuff in there at all, particularly no reparable infra, it looks like. So if you want, and it depends on her Parkinson's and her disease state, right? I mean, if she's a physiologic, 67, 68, I think Steve's right that, you can predictable sort of get a reverse, but her motion looks good. So on one answer, if you sort of force it, I'm going to give her a trapezius tendon transfer. But it's not without some pause. The Hamada classification becomes relevant on all of these things too.
Grant, how about yourself?
Yeah, I think it really goes back to the patient's chief complaint, right? So if it's the lag sign that's the issue, exactly as Paul said, that's leading me more towards tendon transfer. If it's pain, then maybe I do a reverse or an SCR or something else. So I really want to focus in on what she really wants out of this shoulder, because you probably can't get her everything out of this. You're not going to give her full strength, full motion, no lag, and a durable shoulder. You also want to know about the Parkinson's. Some people with Parkinson's are very rigid, and so you really want to educate them about stiffness, especially if you're doing something that like a tendon transfer, you're not going to move her very quickly. Some, because of the medications, have that kind of hyperkinetic dystonia, and that can be a risk also for repair. So if they're one of those two things, I might actually lean more towards a reverse, just because, I don't want my repair to fail. I don't want them to get stiff. Something where I could get them moving quicker might be the deal. But I think if she's kind of a relatively high functioning person, really wants that lag sign and that weakness better, I think a tendon transfer with a lower trap is the way to go.
So we have our revision cuff patch. How about bridging? How about bridging remaining tendon versus an augment? Anyone bridge? Paul?
Bob Tajman still speaks about his bridging technique, and he's a superior technical surgeon, but I have not really kept that in my armamentarium.
How about reverse with lat, Steve? Would you let her go back to lifting and swimming and things like that?
So to qualify my answer in reverse, I think if I did a reverse on this patient, I would also do a lat transfer as well. I mean, I think if her most notable physical finding is that ER lag sign, I find that a lat transfer can really help with that. And then as far as return to activities, I'm not sure that I would necessarily kind of like really push her to do it, but I would kind of let her make her own decisions as far as what she does.
Steve, can I ask you a question here? I don't mean to jump in on him, but I just did a lat transfer last week, and the fellows were waving this paper by the folks at Ortho Carolina about how a prospective level 1 randomized trial and lat transfers don't do anything for loss of ER. My experience has been like yours. I feel like it helps, but I'm curious the rest of the panel. Has anybody abandoned the lat transfer in light of that level 1 evidence?
I think it's really multifactorial on what prosthesis you use, what their pre-op motion is. Maybe it's a tenodesis. Maybe you're just cutting the lat and allowing external rotators to work better against inhibition from the lat. So I think there's so many papers that go back and forth. So I'm gonna take you through. So we decided, because of her age, her motivation, her host status, to do a lower trapezius. So it's really, if you go into the lab and study how to do this, it's the only attachment to the medial aspect of the scapular spine. So we do this all in the beach chair position. We pull them over, and there's a layer of fat you have to excise off the superficial part of the lower trapezius, and then work from lateral and underneath. And then you can usually, after you've done this a few times, it becomes, because this is really the biggest part of the operation, is able to mobilize the lower trapezius tendon and find that insertion point and reflect it off. And this is, we're opening up the infraspinatus fascia here to create our tunnel into the subdeltoid shelf. Now we've already, my assistant or fellow or resident, they've already prepared the graft, which is an Achilles tendon graft. We want it to be at least 26 millimeters. To me, that's not reparable. Maybe some people would patch that or augment that. And then you just bring it in through from posterior to anterior. There are many different ways. You can push the graft through, you can pull it through. Here we're bringing it in using a clamp from anterior to posterior. We're visualizing from our lateral portal. And here's our graft. We're gonna feed that through. And it already has 4 strands coming out anteriorly that you then just put into the tuberosity at the anterior footprint near the bicipital groove. This is kind of an older video where you can use simple anchors and pass them through the tendon to cinch it down to the tuberosity footprint. We actually preload the Achilles now with simple sutures, and it's all knotless. So really, if you can do any kind of cup repair, it's very simple to do. So this is the finished repair to the tuberosity footprint. We want to make sure the excursion is nice. We really cycle it a lot, 10 to 15 cycles. And then I usually repair it in abduction, external rotation. So here's our lower trap. Here's the Achilles. And you can utilize any type of burrito, taco, pulver calf, whatever your best fixation method is, to repair that back down together. And then as we get to the end, you'll see that the excursion is really nice. And you want to make sure that the excursion into the subdeltoid region is easy. So that's the lower trap. This is her 6 months later.
And again, please.
And so it's her right shoulder. She's also had a cuff on the left. And if you look really closely, she's really skinny. You can actually see the trap going into the subacromial space, or from posterior to anterior.
Wow.
And so she was pretty happy. We're in a study now that's studying these with MRI. And so I would tell you 90% plus heal in this method. And you can see the lower trap coming in, attaching to the tuberosity footprint. So give me some learning curve things, Paul, about lower trap.
So Anand, I think you pointed them out. The first learning curve thing is that if you're going to do a complex cuff repair with a dermal graft, or if you're going to try a SCR, this is no more technically difficult, particularly on the arthroscopic side, if not easier. In my experience, I'm going to want to repair the front edge of the subscapularis if it needs repair, but that's going to be a predicate for this being successful. Then I'm going to try and repair any infraspinatus up to the back before I start to engage in bringing my graft in. So I want to create as much of a suspension bridge if possible. Often there's not a lot there to get. Just as you suggested, I'm going to make a transverse incision on the scapular spine, and I'm going to cut out aggressively that fat pad that overlies this tendon. And then by using a Cobb elevator, I finally find something shiny. And you showed in the video where you reached underneath with your finger. Once you're able to do that, then you don't want to dissect beyond the medial border of the scapula, so you denervate it. And there's some variability. Some people have a very big, beefy muscle. Some people have less, but there's a real fascia on the undersurface that you find.
Right.
And that's the hiccup.
You can get small lower traps in really big people too, so it's interesting. Steve or Grant, any tips? Do we burn any bridges by doing a lower trap? Steve says eventually she's going to need a reverse.
Yeah, I like it. I thought that came together well. Obviously, she's happy based on that level of function. I think Grant was right. I mean, the key is kind of what's the patient's primary complaint. I have a question though. So, I mean, at this point, is there an isolated lat transfer? Is that in your toolbox at all anymore, or has that been replaced entirely by this muscle transfer?
I never had great success with latissimus transfer for posterior superior cuff. It was a long, hard operation, especially in big men, and it ended up being really wispy, and it didn't really make sense to me because it's not in phase like the trapezius is. And just by doing a lot of it, I've seen the results now. So it's not in my armamentarium anymore. I haven't done a lot in a long time.
But for a subscap or an anterior transfer, you would consider it.
Yeah, definitely.
Yeah, I agree.
Comments?
I was just going to say one point on this too is, the rehab. So it's not like your standard cuff rehab. I don't know how you guys do it, but I do it the way Boston does, where I have them in a abduction external rotation brace, and they really try to be diligent about staying in that. And if they come out of it to bathe, it's very careful. I don't want that arm to come down because at the very least, I want that tenodesis effect. I don't want things to stretch out. Are you guys pretty rigorous with keeping them in that position?
I have them in an ER brace. We tell them never to cross the midline for 6 weeks. They actually do pretty well maintaining that, and then we rehab them like a cuff from there. Passive first, active assisted, no strengthening for 3.5 months.
I use a regular abduction splint because I don't find compliance with any kind of lurman or anything like that, and I do no PT at all for 6 weeks.
Excellent. So, I mean, I think that's been a big change in my practice is the lower trap over the last 2 to 3 years, and hopefully we'll get some good literature on that in the future. So this is another young patient with a bad problem, 44-year-old female. She's had all the conservative treatment. Now you see the difference here is that she has really poor motion. She has 40 degrees of elevation and some minimal rotation. She can get to her hip. She's a runner. She likes to run. She's kind of lives a little bit far away and didn't have great medical care. She was in, I don't want to say it, but she was in Greenwich. But this is her. We have a pipeline. This is her films and MR. So, Steve, your turn. Steve, your turn. I don't get any stuff from Charlottesville. It's interesting. It's good, good medicine down there.
That's what we don't like brown guys.
And Chicago's too far during COVID.
All right. So if this is a Greenwich patron, changes things a little bit. But no, I mean, this is obviously a very dire circumstance. A young person, I imagine dominant arm. Both the infra and the super are largely gone from a muscle standpoint, so not so good there. Functionally, so I'm assuming those range of motions are both active and passive, so she's pretty stiff as well.
No, she's not stiff. Her passive motion is probably like 100 or so degrees before it begins to hurt and impinge. She's got a little bit more passively, so it's not a completely stiff shoulder, but it's not perfect. And she hikes. She has that trapezial hiking when she tries to raise her arm as well.
Yeah. So, I mean, you can see all the hypertrophy of the teres minor, so trying to compensate there, but obviously not doing a great job of it. So, honestly, I would say similar to the last case, you're talking about salvage stuff, and so either reverse arthroplasty plus or minus tendon transfer, or you could, given her age, give a kind of a swing for the fences with like a superior capsular reconstruction here. But I haven't really been impressed that SCR has the ability to overcome true pseudoparalysis and with the external rotation deficit as well. It's a large ask in this patient. So that's more of a conversation with the patient as to whether or not they're willing to go for it.
Grant, how about you?
Go ahead, Grant.
I mean, this is a very dire situation. So just to be clear, so she's not really stiff. It's just the active motion is so poor. Am I understanding that right?
Correct.
I've done cases where I've done SCR and lower trap in the same patient, and that has not worked out well for me, quite honestly. Technically, we're all high-fiving and great pictures and videos, but the patients it hasn't been a home run. This is a patient where I have an honest discussion about reverse total shoulder. She doesn't run on her arms, so maybe she'd be okay with that, even though she is active, as long as she doesn't have a lot of upper extremity demands. Again, she's so young. I get that's fairly aggressive, but
Doctor, how long is this going to last me? That's the question they're going to ask you, right?
I tell her you have a 91% chance of it lasting 15 years and beyond. And then after that, it's going to fail at a rate of about 1% a year. That's sort of my synthesis of the literature. And so the bottom line is there's a very, very good chance that in her lifetime, she will need it revised, number one. And number two, that a revision reverse can be a very challenging proposition and sometimes not even possible if there's too much bone loss. So, you know, and she's going to tell me, listen, I can't live like this, and these are the best years of my life, and let's do it. And as long as she understands that, you know, and there's a shared decision-making paradigm, I think that's okay.
And based on her X-ray with the changes on the acromion, Pat Denard's data says SCR is, you know, less than 40% chance of working in her. So that's an important, you know, you have all your fancy MRIs up there in Baltimore. Simple X-ray tells you a lot about.
How about two other things, Steve? How about a hemi in this case, and how about this bursal-sided undersurface acromial resurfacing, reverse SCR? From England.
So I've never done a bursal. I've never done a bar procedure. I'm not sure that I'm solid on what the indications are for that. It's, you know, to my mind, it's kind of probably like the subacromial space balloon, which you didn't throw out there as well. Another thing that I've never tried, but actually might be a great option in this circumstance if her primary issue is pain. Hemi, I don't know that I still keep Hemi in my algorithm. And mostly is because what Grant said is accurate. Reverses are actually holding up pretty well. And so the big issue with the reason we did Hemis was because we were worried that the reverse was going to fail in 8 or 10 years, and then you'd really have no options. But as long as the patient's appropriate and reasonable, I think, you know, for a 44-year-old, a Hemi is not going to give him a great result. And you know, so I probably feel more comfortable recommending a reverse.
What indications?
Here. So Steve, what's your procedure here?
For me, as much as I hate to say it, this is a reverse for me.
Paul?
Reversomania. I'm in.
Grant?
Reverse, absolutely.
All right.
From the jump. So
these are her expectations. She's got this poor function. We talked about the options that are available. So she was in the IDE study for balloon, for the orthospace balloon. Fortunately, she kind of came through during that period of time. This is her pre-op and about a week post-op X-ray. Does that look better?
Axillary nerve to do that, or how did you get her?
Does her X-ray look better now, Paul?
I'm interested though. Honestly, it's amazing. I would guess that her capsule would have been contracted and not allowed her to sort of sink down so much. And you're not allowed to do capsule release in this case, right?
You do a limited burstectomy. You can cut the biceps if you have to. No repair. It's randomized, so she was randomized to the balloon. This is viewing from posterior. You can kind of see in a minute here how the humerus is depressed. And I don't mean clinically, but depressed. And you then measure the amount of fluid to put in, and I won't get too technical about it, but it's a very simple procedure to do.
Did you use like an air compressor to inflate that balloon? That's an incredible amount of inferior
fluid. It's just fluid. It's just fluid. This was a medium or large.
Is this a real case? Did you make this case up?
And this is
it's like a car jack. It's like a car jack, like you're changing a tire or something. I love it.
Her 6 months post-op. And I will tell you, I've seen her now 2 or 3 years after that, and the results deteriorate in time.
The X-rays look like a year or two.
She still has over 90 degrees, and she's active, but not as good as it was before. But she's not close to getting a reverse again. So hopefully, you know, I've just heard from Stryker that hopefully this will be available this summer or late summer, and hopefully we'll get that and have that in our armamentarium as well. I think it'll really add to the treatment of complex cuff disease. Anybody else have experience with the balloon?
Anand, can I ask a question?
Yeah.
So you know, we think about things that are going to change the mechanics. So this doesn't really change the mechanics unless you think that maybe they can rehab and get those forced couples and that big teres minor that Steve pointed out working. If it doesn't change the mechanics and it, you know, when it goes away, they should go back to where they were. So 2 questions. One is, do you think that somehow through therapy during this time where you've improved their center of rotation, they can kind of get back to a compensated shoulder, number one? And number 2 is, you know, if this failed, can you just do another one in a couple of years? I mean, maybe that's not such a bad thing if it buys her a little time.
So I think if you have a teres and subscap, it's probably a good option for you. The studies out of Europe where it's been available, people have done it 1, 2, 3 times, you know. People are doing it like a kyphoplasty under just radiographic imaging, even not without arthroscopy. Terrence, are they using the balloon in India yet, or is it available there?
No, Dr. Anand, we don't have the facility of using spacer. Probably we have Samantha, Dr. Samantha here. He is a
Hello.
Also
Good evening. Good evening. In India, it is not available over here. So it is not available in India.
Samantha?
So yeah, it is not available in India.
Hopefully it's available worldwide soon. And I think it'll really help. It'll really help our patients. So here's another tough case. This one was actually referred from Greenwich to Virginia, interestingly enough. So 40-year-old female, this is Steve's case, I believe, had an open capsulorrhaphy. Dr. Sethi forgot to repair the subscap, I think, on the way. He was busy, had to get to golf match. It's worsened over the years. You can see she's got good motion, but hyperexternal rotation, and obviously symptoms and signs of subscap dysfunction. Sethi sent her to Chicago. Actually, I think it was Duke at the first, and Grant tried some metal anchors, but that doesn't usually work as well. Sorry for the patient. So this is her MRI. Now that she's in the hands of the excellent Dr. Brockmeier. Grant, what do you think? We've got a failed open procedure, failed capsulorrhaphy. What are we going to do here now? Young patient.
Yeah, so we're missing the largest and most important rotator cuff tendon or largest tendon, certainly. The subscapularis is just gone. Looks like it either wasn't repaired adequately or was repaired and then failed. But regardless, there's nothing attached to that lesser tuberosity. It looks like it's retracted medial to the glenoid. That's not significantly, significant fatty infiltration. So that's not a repairable subscapularis. That's a difficult problem. And since it's not repairable, you're looking at tendon transfer options, for this young patient.
What's your option here?
Yeah, so the ones in the past I've done subconjoint split pectoralis major, and that worked okay. But I'm very excited about the yes, use the hands. But I've done some lat transfers, and it's much easier and seems to be more effective. The one I'm watching closely is some folks in Europe are doing pec minor, where very similar to how you show the lower trap, they're taking the pec minor off the coracoid, lengthening it with the graft, and then using that. So for this, bottom line is I would do a lat, but I'm kind of watching the research on that pec minor.
Pec minor is really small. I mean, I've used that for some other things. That's interesting.
It looks small where we look at it. It gets bigger as you go medial. We're not over there so often.
So don't mess with Goose. He says use the lat. How about you, Paul?
I would double it up. I'd use a dermal augment and do an ACR, and then I put the lat over that to beef it up.
So describe how you're doing that. Arthroscopic, open.
I would one day like to get there arthroscopically, and I believe there are surgeons doing it. But for me, with previous surgery, I'm going to do an open surgery here. I'm going to expose the medial glenoid. I'm going to place anchors on the medial glenoid. I'm going to put a tight sheet of dermal allograft across to the lesser tuberosity, and then I'm going to share the anchors on the lesser tuberosity where I can bring the lat up and then sew the lat in a side-to-side fashion into that dermal graft.
So this is what Paul really gave the patient. He said, take two of these. This is $5,000. It's cash only. This will cure your
Venmo.
Venmo directly to my offshore account. So this is the voice of reason, Dr. Brockmeier. Brock, what was your planning and your thought process here?
So I agree. I kind of sided a little bit more with Paul's approach. I do think something to because she was kind of statically and dynamically unstable to the front. She had a stabilization with the subscap had failed. There was actually some subscap still findable. So you'll see in this video, we took the biceps, Paul, for you. Used a button obviously to fix that.
Obviously.
And then, but if you see here, there was some tissue in the front that I thought was somewhat salvageable. So if you bear with the kind of choppy view here, there was another gap that I did not do a tendon transfer, but we did, however, do an open dermal graft a so-called anterior capsular reconstruction. So you can see here, delta pec. That's what we found, like that. And
That's the
I'm not sure how
remnants?
well the video is coming through.
Yeah, it looks good.
What's
That's the remnant of the subscap?
Yeah.
Okay.
That's the remnant of the subscap there. So we got that freed up very immediately. And then you can kind of see, got the joint exposed and laid a dermal graft here. So we kind of freshened up anteriorly and a couple of anchors on the anterior part of the glenoid, not up on the face, but kind of up on the neck. And then a tight dermal graft, fixed it to the lesser tuberosity. And then on top of that, then did a similar repair with the subscap. So you can see here's the dermal graft, thick graft, like a 3.5 millimeter graft for this, something pretty burly. And,
how do you determine the position of repair and the tension?
So I fixed it to the glenoid first. You can see here we've done that. And I used some knotless tensionable anchors to do that. I used 3 anchors in the glenoid because I'm worried mostly about it failing there. And then you can see here, position the arm. And I put the arm, I did it kind of tight. So I put the arm at about 20, 25 degrees. And then, you know, pulled the graft over and kind of figured out where it needed to be. And then passed sutures at that point, tied it down. And then you'll see we excised excess after we had tensioned the anterior dermal graft. And then just brought the subscap on top.
I have a question. Just are dermal grafts available in India? And if they're not, can we talk about using a hamstring as a substitute as we talk to our overseas colleagues?
Terrence or our other colleagues in India, any comments on using grafts or graft availability?
No, it is not available in India. And so whenever we have to add on this thing tendon, we usually use the tendon grafts.
Have you ever taken autograft, tensor fascia lata, or anything like that to graft a patient?
Yeah, we are doing with the tensor fascia lata also, but most of the time we take the semi-T.
Semi-T.
And I think the semi-T, you know, that's the point I was trying to bring up. For everything we've shown today, whether we call it SCR or whether we call it lower trapezius, you can use the semi-T in a zigzag Z fashion, you know, on the anterior capsule, or weaved into the lower trapezius. Maybe even
that was traditionally, and that's what I'd used in the past, is, you know, Meckel described the Z fashion using, you know, IT band or using semi-T. It works really well. You can tension that too, but I like this thickness of this dermal graft too. So what are your thoughts on ACR, Grant? These guys are talking ACR instead of lat transfer.
I would have done a lat transfer for that. I think the lat transfer gives you stability because of that posterior line of pull. It's very easy, and it's going to also give you some dynamic, potentially internal rotation. So for me, I mean, that looks great. It's a beautiful video, but in my algorithm, you know, that's clearly a lat transfer situation.
Wow, Steve, how's she doing? Because Grant just said that's useless, pretty much.
So she actually moved to Chicago. No, I'm just kidding. So she's not that far out yet to kind of know what the final outcome is. She's actually about 3 months out, so far enough out that I've known that we can tell it's not an abject failure. She's actually not having pain. Function's improving pretty well. I mean, honestly, she's thus far doing quite well. I've done now 2 of these. One of them, the first one was actually on a woman who's a nurse in our outpatient surgery center. And so I see her like every week. And she's done actually really, really well. So, you know, this isn't something that I've used commonly, but I'm cautiously optimistic that this is at least a reasonable salvage option for this particular circumstance.
Dr. Swanendi, you had a question?
Yeah, Dr. Anand, I have got a question for you, because when we compare about the subscap, this thing, supplement like your lat dorsi and also your this pec major, or do you have completely shifted to lat dorsi LD? Or some people are still doing the pec major?
I'll touch that for a second. I think the best results of pectoralis transfer have been published after insufficiency for instability surgery. That said, the pec sits anterior to the scapula and the lat sits, the muscle belly sits posterior to the scapula. So the lat's really much more anatomically in line and will offer a posterior vector sort of stability. So I think Grant's choice to use lat there is more 2021. No one's done a comparative study looking at the 2, but it does seem to make more anatomical inline sense.
Yeah, nowadays we are more shifting towards the lat dorsi for this rather than the pec major.
Yes.
Agreed. So that's a great case. I think Paul has an ACR too, right? Paul, you did one after arthroplasty, is that correct?
That's correct. I had an acute fall, and I did exactly what Steve did. Is I tried to sort of find some subscap stump. It was a fall about 3 months after a total shoulder in a young person who had retained motion, but not with some issue, and I wanted to try and gain some stability.
Excellent. And she's doing okay?
It's about 3.5 years now, fortunately.
So this next case is a 65-year-old male, chronic pain, failed cortisone therapy, PRP, turmeric, acupuncture. You can see the motion is okay, but very weak with pain. These are the preoperative images that we see. Some mild arthrosis, maybe Hamada 1. This is the MRI. So 65-year-old, subscap looks good. Grant, what do you do in a 65-year-old? Is this a reparable tear in your practice?
Scroll through it there one more time.
Yeah,
I don't.
Anand, I think this is repairable.
Okay. Grant, can you see it?
I can see it. It's obviously got a significant level of retraction. It's not terribly huge front to back in the anterior posterior dimension. It's kind of that classic male pattern baldness, supraspinatus tear. Is that knee? It's the same glasses. I can see the glasses.
It's a representation.
I'd love to see some cuts that show fatty infiltration. For me, that's the deal breaker.
He failed the first rule of this. You never ask for more imaging. So what are you gonna do?
Instead, I'd love to. In a perfect world, I would enjoy seeing those.
Paul, what would you do here? Actually, I'm gonna ask Steve on this one. Brock, what would you do here?
Probably try to, based on the limited imaging that you're providing us, I would probably try to fix it.
Do you ever make or tell your patient what your options intra-op are going to be? I might do this, I might do that, depending on something else.
I see all those in second opinion when you confuse the patient and send them out with 7 different plans. So you tell them you're going to fix it, and if you have to patch it, you'll patch it. You give them some granularity.
So Paul has the answer here to this 65-year-old patient. So why SCR in this case?
So I probably wouldn't do an SCR in this case. Sorry, but I think that you would consider something arthroscopic as opposed to a reverse or a patch here. And I would consider a biceps SCR here. So I would use his own biceps, pull it out of the groove, put it up onto the top of the tuberosity, and get a partial repair of his infra back into that. And so it's a partial repair plus without adding the complexity of SCR.
The nice thing about SCR here is that you can go in and attempt to repair it and tell the guy exactly as Paul said, hey, I'm going to try to repair it. And if it can't be repaired, then I have this backup plan. So,
it's pretty funny that Paul would say, I wouldn't do it since this is his case. I guess he forgot what he sent to me.
Can't remember yesterday. Come on, man.
So this is Dr. Sethi performing a superior capsular reconstruction. What are your tips for SCR, Paul?
I just think it's about organization, right? Get all your work done first, address your subscapularis and your biceps, get your infra done back in place. And then we want to get 3 strong points of fixation. Glenoid, the way Steve was talking about with the ACR. You really want to slide it down and make sure it doesn't flip over. You want to get the length and the tension as right as possible. There's all sorts of different cannulas where you can split the sutures in different ways, but it's just it move slowly and efficiently and don't tangle your sutures. And it's just another arthroscopic procedure. The thing that I honestly do most differently now in 2020, 2021 is that I take the cuff that exists and I repair it over the top of the SCR routinely to create some kind of sandwich procedure.
Steve, what are your indications for SCR in 2021?
So for me, I think, hard stops are any significant arthrosis. I mean, I think this case would be one where probably not enough that would be a hard stop. But, if you think there's arthritis-based pain, then an SCR is not going to work. I think you need a subscap. And so, I mean, if they have a little upper border like you showed in that video, I think you can certainly repair that. But if they have a complete subscap, even if it's repairable, I feel like SCR just doesn't work in that circumstance. And then some of them are going to be patient variable. So, pain versus function, age, biology, if they're a smoker or diabetic or something like that. So, I mean, I think this is a pretty good indication for SCR if you can't fix the cuff. I guess this one just looked like one where I could fix the cuff. And I agree with Paul, if you can fix whatever you can fix, if you're doing an SCR to augment it by repairing the cuff that's still repairable, certainly makes sense to me. And so in 2021, I am trying to do that more and more.
Grant, what graft do you use, and do you repair a cuff over the top of an SCR now if you feel that's going to give them a better chance?
Yeah, so as Steve said, certainly I try to repair as much of the existing cuff as I can, and usually you can get some infra or even advance the infra a little bit. Am I ever repairing the cuff like the supra over the SCR? I've done that one time in a military sniper who was being deployed as a, quote, observer for the U.S. Special Forces, which he said described as being observing very bad guys through the scope of a high-powered rifle. So this guy was going to have a rotator cuff repair. I wasn't sure it was repairable, and he was going to be doing military duty in about 4 months. So I felt like I needed to augment it. That's a very unusual situation. Typically, I think if you're able to get that supraspinatus over, there's no reason for the SCR. You're considering you're doing the wrong operation, in my opinion, and you're taking up valuable footprint space. So for me, if I can repair that cuff, I think there's no role for an SDR.
That's why Grant is not in this picture drinking Kool-Aid, which, by the way, for the record, there's only Kool-Aid in the picture.
It's only Kool-Aid. So Paul likes to make us think about the Kool-Aid, but I think there is a question about how much footprint space is available to do all these different types of augments and SCR and cuff at the same time. So be cautious in that. And this guy did great because Paul's an outstanding surgeon. You can see he's got his rotation and wonderful outcome. Excellent. All right, so we have, let's see, we have about 10 minutes. I'm actually going to move forward to another case. Sorry, Paul, your reverse did great. So this is a 43-year-old male, young, lifting some heavy stuff. It's probably Paul. History of bodybuilding with steroid use, has good motion, but he's weak. Good-looking X-rays. What do you think about this, Steve? Any issues with this MR? Are you concerned about?
Well, I mean, so I'm assuming the injury was weightlifting, correct? So there's some acuity here, and it froze up a little bit. So I'm not sure if this is a delay. And thanks for the circle. That's very helpful. If there was a delay in treatment, but these acute tears are obviously a different animal. He left some tissue behind, as the imaging is showing us here. So that's also something you have to take into consideration. I'm trying to tell as much, because sometimes they'll tear at the muscle tendon junction. Sometimes they'll just kind of transect the tendon. But in a high demand individual, acute tear, this is one where I repair it, and I actually probably augment it as well, like a dermal augment.
So this is what it looks like intra-op. Does this worry you at all? I mean, there's a lot of chicken left on the bone laterally there.
For sure. Yeah, but I mean, there is some tendon still left on the muscle too, maybe a little bit. So I think you can still repair these. I'd probably try to repair it more medially to the footprint and then try to incorporate a graft on top. So we talked about this earlier about single row versus double row, but for these, actually, I kind of do a little bit of a hybrid where you have some double row sutures that are passed really mostly to hold the graft, the dermal graft in place, and then really do a single row repair of the actual patient's tendon back. The double rows go through the patient's tendon, but you tie it down after you've secured the single row so you don't over-lateralize this.
I agree with Steve. What I would probably do in this case is I would medialize the articular cartilage by about 4 or 5 millimeters, place a single row of anchors across that medial side, and then place, like Steve said, a big tape ripstop stitch. I tie my medial anchors in to get my single row repair, and then bridge out my ripstops out into the lateral row, because there is tendon left behind on bone.
So Grant, take us through what you did. This is a difficult case. What was your thought process?
Yeah, so very similar to the panel. This is my case, as you said, and basically this is steroid guys. They have huge muscles, but the tendon gets tendinopathy. So this is a true intratendinous rupture. There is tendon left on the medial aspect, exactly as Steve said. My plan, I had a graft ready, and when I got in there, the tissue that was left on the tuberosity was not that typical kind of tendinopathic tendon that you see with your kind of obese, high cholesterol elderly patients. It was actually decent tissue. So what I did was elevate it up from medial to lateral and just kind of leave the tendon that was left on the tuberosity still attached and use that essentially as my graft. So I medialized the footprint.
Oh.
I repaired the rotator cuff to that. You can see kind of on the left side of the screen, there's the graft. I had sort of a traction stitch to pull it out of the way. Then brought my medial row sutures up through that tissue and then basically used the remaining tendon as my graft.
So this is what it looks like. You're looking from a posterolateral portal, I'm assuming, or some type of
That's either
portal.
lateral, posterolateral. That's exactly right. And you can see that's kind of the native tendon. And then under that, in almost a pants over vest type fashion, is the ruptured tendon is sewn in under the remaining rotator cuff.
What do you think, Steve? How do you do?
Sweet. I think that's a really nice option to do, Grant. Sometimes I feel like the grafts sometimes kind of create this like kind of barrier so you don't get adhesions and things of that nature. So, I would have approached this just like you, having a graft available, but honestly, that looks great. Pretty cool way of repairing it.
Paul?
I like it a lot. I just wonder if everyone's going to have enough excursion, that 5 millimeters or 6 millimeters extra excursion to duck it. But in a young guy with good tissue, that's awesome.
And that's a key point, because these patients, a lot of these people with this kind of rupture, that tissue laterally is junk. So I think, again, this is a young steroid guy. This is kind of a unique situation, but it worked well for him.
I'm not sure why Grant sent me a guy who had a distal biceps repair, but yeah, his cuff is probably doing okay as well. But
that's his barber. That's hairdresser.
I think I really want to get this case into. It's a different concept. This is a 67-year-old equestrian. Terrence, can we go a few minutes over if we have to?
Yeah, go ahead.
All right, thank you. 67-year-old equestrian, fell off the horse, a lot of pain, injury, but you can see the function is relatively good, actively not as great. X-rays look okay. What do you think about this MRI? Let's start with Paul.
Looks like the subscapularis is intact. The superior cuff is highly deficient, although there's reasonable muscle belly as you sort of flip back and forth. It's scarred up against the acromion a little bit, speaking of some chronicity.
How about you, Steve? Are you worried about this 67-year-old?
Yeah, I am. I mean, this is so what the time frame between the fall and when you're seeing this patient is how far?
About a year.
Yeah, it's delayed. So these are tough. I have a couple patients like this, and in my stockpile that I show, because these are tough cases because they end up being really stiff. Most of the time, they'll have a bunch of adhesions and they end up being really stiff. And then the tissue is often just not very good tissue. And so you get in there and you try to repair it, and it used to be an acute tear, and now it's like something different.
So this is what it looks like. We got a little infraspinatus repair. Supra looks like garbage. What are you going to do now, Paul? Just leave it and rehab a partial, which has some good results?
This is the one I keep talking about, the same biceps SCR, but this is, once again, I'm going to use this as a workhorse here. I think a partial repair can be very effective in terms of pain relief and functionality, and I just might throw their biceps in there because I believe that it enhances the healing and the function.
How about you, Grant? Do you believe in this biceps stuff?
Yeah, so I haven't done it, but I have read the papers on it, and I think it makes sense. I think there's good results with partial repair.
Grant cut the biceps on the way in, Paul. That thing's gone.
I think you could. Certainly, partial repair has good results, but while you're in there, you might as well do something to give you that superior restraint, superior translation as well.
Steve, any experience with the biceps?
I think it's interesting. So, Paul, when you do this, you attach it like you try to reconstruct it says your anterior cable. So, like, that rotator cable in the front, right behind the biceps groove. Is that what you're shooting for?
So what I do is I release the lateral bicipital sheath, right? So I can get it all the way up and out of the groove.
But let me. Why don't I show that this is probably what you do, Paul? But maybe you can comment as I play the video. These are some stills from a left shoulder triple loaded anchor repairing the infraspinatus. And then we'll show you what the plan is. It acts as a suspension bridge, essentially, where your infraspinatus is repaired. There's no supraspinatus, but you still have this good biceps tendon. This is described by Max Park and Ty Lee. And the goal is to use that as a suspension bridge for your infraspinatus when you have a deficient anterior cable. So let's go through the video here. So this is Max Park's case. Similar bad cuff, joint looks okay. He's in the lateral position. So this is after our partial repair of the infraspinatus. And now the goal is to pass sutures around the biceps and the leading edge of the infraspinatus, but you've moved that biceps just anterior to your repair. So here's our biceps tendon. Quality's pretty good. You create a groove for healing. You move the biceps into that position, and then you're going to tenadese it there, and then pass sutures around, not through the biceps, but around the biceps and through the infraspinatus. Paul, is that what you do? Do something different?
I mean, more or less. I don't create a groove. And I learned this technique about 2 years ago in Ahmedabad, India. And at first I was like, no. And the most interesting debate that I have, and I've not had resolve on, is whether or not I leave the biceps intact distally. Can it act as a depressor if you leave it fully intact? And is it more vascular, or are you going to get bicipital pain? I have about 8 of these now that I'm following. None of them are more than a year, so I can't report on it. But you know, they're all doing reasonably well. What is the experience in India? Because I believe this is where I learned this technique. So how are you guys doing it? You leaving the biceps intact?
No, yes, no, we are not keeping the biceps intact. We are just we are doing the biceps SCR, but we are cutting that over there. We are not keeping the biceps.
Results you've been pleased with?
We are happy with the biceps SCR. We are happy with the biceps. If it is irreparable cuff, when we are doing the partial cuff repair, then we are augmenting with the biceps SCR.
And when I tell you how easy and sort of straightforward and on the fly, the only thing you have to do is in your mind, you have to sort of change your paradigm shift to like, am I knocking the biceps out of the case during my intra-articular assessment of this case, or do I have to wait until I've gone subacromial to make the assessment? And that's a little bit of a thought change for many of the American surgeons.
So do they have to move the biceps, or can you just, you know, tenadese it right in the groove? Because that's so close to where that anterior cable attaches, you know, right there where the biceps
So you have to be able to get excursion from the infraspinatus to, at least in this technique, be able to get the infraspinatus to your biceps tendon as well.
Right.
And you
I think you need
also
to change the vector.
And then Max will tell you that you have to do this in about 30 degrees of abduction external rotation, or the transfer, if you will get stuck and cause stiffness. So I mean, I think it's just another option. I think the biceps is coming back to some discussion. We're testing this in the lab now, and hopefully we'll have some clinical results with Max and his team as well, and Paul. The other option, obviously, is to use a dermal graft. So I'm going to end. This is 9 months post-op. I am going to end there as we are at 10:58. I want to thank everyone. Terrence, is your team? Do they have any questions for us? We really appreciate the time you guys gave us today.
Thanks, Dr. Anand, Dr. Paul, Dr. Steve, and Dr. Grant. As you said, really we enjoyed it. It's amazing and a fascinating team who had a wonderful case discussions. I think rather being a monotonous speech, I think this sort of case discussion is definitely interesting and makes us more intrigued about the shoulder complex rotator cuff 8 years. We have our faculty here, Dr. Swananda, Samantha, and Dr. Chokalingam. Probably they can have questions, and after that we have few questions in the Q&A, and we can take over and wind up. Dr. Samantha.
Yeah, basically we have discussed, the cases were really excellent, and we have discussed in length what should be the options in the complex cuff tears. I think Terrence, we can take the questions.
Okay. Question to Dr. Chokalingam. Dr. Chokalingam, are you here? Okay. Question to Dr. Anand Murthi about the spacer you have been used as a balloon surgery. The question to him, what was done with the biceps when you're putting a spacer in the subarachnoid space?
So in that study, you were allowed to choose what you could either leave it. We usually did a tenodesis because these were usually chronic rotator cuff tears. So you were allowed to do a tenotomy, and I usually do a subpectoral biceps tenodesis. But there was no, you weren't allowed to do any cuff repair or partial cuff repair. But the indications when you did the initial scope, they had to have an intact subscapularis and an irreparable cuff.
In all your cases, did you have any glenoid cyst, or did you have any cases of cyst compressing the nerve, causing the infraspinatus or supraspinatus weakness?
Paul, you want to take that? Your treatment for paralabral cysts?
Yes, Anand, I think he's referring to the paralabral cyst. Yes, sir.
Yep.
Yeah.
Do you have any comments, or Grant? Or
So
and nerve relief?
Sure. I'm sorry. Were you asking about having trouble with the nerve after the setting of trapezius transfer, or just in general?
Just a cyst, a paralabral cyst compressing the nerve. Completely different topic.
So I think that's a situation where you could probably get away with an arthroscopic labral repair or biceps tenodesis and just take care of that problem, because usually the cyst is leaking for it. You can often decompress the cyst through the labrum, or if the labrum is not torn, through the capsule. And I don't find that you always need to do a suprascapular nerve release in that case. That's my opinion.
Yep.
Anand, I have got a question. All the faculties, I've got a question, because what is your specific indication for doing the suprascapular, arthroscopic suprascapular nerve release in your retracted or the complex cuff tears? And what is the percentage in your surgery?
Grant?
So yeah, for me, I'll do that as an isolated procedure if I think they have isolated suprascapular nerve entrapment at the suprascapular notch. But that is a different animal. In the setting of a cuff tear, there's good data from J.P. Warner that shows that if you are able to repair the rotator cuff, the EMG findings return to normal. So if I'm able to get that supraspinatus over, that nerve's not going to be kinked, at either the suprascapular notch or spinal glenoid notch. So that I'm not worried about in that setting. I think if you have somebody who has some infraspinatus, high signal, some neurogenic edema, where the infraspinatus is not torn, and you can't repair the suprascapular nerve, there may be some role in that, but it's such an unusual situation. I find that I do not release it that often in my practice.
Steve?
I think Grant summed it up. I don't do it as a routine part of my, cuff repair for large cuff repairs. But I agree, if you can't repair the supra, then maybe I give it some consideration in those patients where they have pretty advanced atrophy of the inframuscle. So like an SCR in that circumstance.
Yeah, but I've never done an SCR and the nerve release at the same time. Have you?
I've done one, frankly. It's not something, it's probably something that maybe we need to consider doing more often. But honestly, I don't know that I noticed that they still have, overt weakness afterwards either. So that's a good question. I honestly don't know what the right answer is there. But that's really the only time it enters my thought process.
Basically, I am also not doing regularly the arthroscopic suprascapular nerve release in my complex cuff tears. That's why I just asked this extinct panel.
I think the pendulum has swung a little. We were doing a lot more initially, and now that we're seeing the results are better just with a repair. I mean, you can do some damage if you don't do the nerve release properly. All right, Terrence, how we doing?
Fine,
Yeah,
thank you. Yeah, probably we'll have quick 10 seconds closing remarks from all the panelists, and probably we can come to the end.
I'll start by just saying thank you to everyone, all our colleagues. This was really fun. We hope we can do this again with different topics and have even more interaction with our overseas colleagues.
I'll follow up. I'm very pleased that I could offer you a lot of revision cases to discuss to the panel. I enjoyed this a lot, and I look forward to our next meeting.
Yeah, I'll just say, there's been a lot of negative things about this pandemic, but the opportunity that we've all gotten more comfortable with this format of meeting in this virtual way has really allowed a international meeting like this. It's a great time to connect with some of my friends and colleagues here and to meet some new friends overseas. So thanks for including me.
Yeah, and I would echo all of those comments. This has been great. As somebody who's never been able to visit India, it's nice to be there for about an hour today and get to share some thoughts with you. And I just want to give a shout out to our moderator, Dr. Murthi, for putting together some awesome cases and leading us through an hour of really a stimulating conversation discussion to the
Samantha.
Thank you, guys. Thank you, guys. And I, being the secretary of the Indian Arthroscopy Society, this is a special regards from all the members of the Indian Arthroscopy Society. From India is a great honor that you people have agreed to have the meeting. And I will request Terrence to organize this sort of meeting from this podium so that we can get this sort of excellent faculty for the shoulder discussion. So special regards and my love extending from my association and from India. Thank you, guys.
Thank you, one and all. As you said, we're not going to stop with this program. And thanks, Dr. Murthi, for your, very special, acceptance for this program. We will keep meeting with other special topic. Again, thank you, Murthi. I'm really indebted for your commitment towards educational motive. So with this, we are going to end and wishing you all safe and healthy at this juncture. And we hope to meet you soon. Thank you. Bye-bye. Stay safe.
Bye-bye.
Thank you.
Take care.
Thank you.